So I'm Karthik Gujja. I'm the Associate Director for the Endovascular Program in Sinai. I think you guys heard my name a couple of times today. I want to talk to you guys about crossing and treating complex lower extremity disease lesions. So very important topic. We really appreciate Abbott for sponsoring this and supporting us through the Endovascular Fellows course. So I'll talk to you in general about the wires. If you guys have any questions, feel free to just come to the mic and ask the questions. Even in the middle of the talk, it's okay. So nothing formal. Keep eating. Enjoy your dessert. So basically, talking about guide wires, we have too many equipment in the bag of endovascular now. So I think too many wires, especially if you're a interventional cardiologist, we carry our coronary wires over to the peripheral side. Too many options. So I'll go over of what kind of wires to be chosen so that you can finish your case faster and effectively. So everything depends, the guide wire, most of the times it depends on what kind of occlusion is it. Is it a long segment occlusion? Is it tortuous? Is it calcified? That's where our things come into play. More than coronaries. If you guys are interventional cardiologists, wiring skills in peripherals are probably a little more difficult and probably more tedious than actually coronaries because the segments are very long. Most of your occlusions are pretty long, at least 15 to 20 cm, and then you have very calcified vessels. So it's very difficult to get from lumen to lumen unless you guys choose the right wires. Again, most of the tibial vessels are pretty angulated. Even the iliacs are very tortuous. So SFAs are usually pretty straightforward to go through, at least angulation-wise. Unless you guys are trying a CTO through the profunda, then it becomes again difficult. So main things to worry about is, are your wires going to reach the lesion? Number one, you have to choose the wire which can reach the lesion. And if you cross, does your wire length enough to get your equipment down there? Second is your wire stiff enough or torqueable enough to get through all the tortuosity? So everything depends on the core diameter, the core material itself, the core taper, grind, and the tip style and the coils. Coils and covers are pretty much the same as any other wires. I think what makes the difference is the core diameter and the grind itself. That's where you have to choose what to do with it. So why are all these things important is because, again, as I said, support, flexibility of the wires, torqueability, because if you guys are going up and over, you will lose a lot of torqueability over the iliacs. They're not like coronaries or they're not like hepatics or renals or carotids, where you go in and the wire torqueability is 1-to-1. In peripherals, the wire torqueability is probably 1-to-2 or sometimes even 1-to-3 or sometimes even 1-to-4. So because you're going up and over, so you're losing the torque on the iliacs, you're losing the torque on the SFAs. If you're trying to do tibial vessels, if you're trying to do plantar vessels, you're even losing the torque on the tibial vessels. So again, crossability, visibility is very important. If you guys are getting used to doing endovascular as one of your career options, you guys have to worry about radiation. It's a lot of radiation. You have to do it, and of course, you guys do it on low fluoro modes, right? Most of your frames are at least 15 to 30. So if you're doing on 15 to 30, your visibility is extremely less. So the wire should be pretty visible because most of the times you don't need fluoro. You can cross it. You don't need dye or anything. You can cross it just based on the visibility of the wire. So that's where the visibility comes into play. So smaller diameter and larger diameter of the core. What this affects is the flexibility and the support and the torque. When you're crossing the lesion, you want to go with a smaller diameter one because you can get better distal access. You don't need that much support to get through. You have support catheters. You just have to cross the lesion. But once you cross in and you want to get your equipment through, you need a larger diameter wire. So let's, how many of you guys are interventional cardiology here? Okay. How many of you guys are IR? How many of you guys have vascular surgery? Oh, not more surgeons. And how many of you guys are just general cardiology? Okay. So pretty good mixture of everything. So because there are less interventional cardiologists here, that's a good thing. So let's not, I won't go into the coronary side much, but most of the wires you guys use are, how many of you guys use command wire? Okay. What's in general your workhorse wire? What surgeons, vascular surgery guys? Just shout out. Zip wire. That's for 035. I'm talking about 014 wires. Command ES, okay. Any other wires? Savian, okay. Anything else? Okay. So I think pretty good mixture. So all the wires you just told are pretty much more like a smaller diameter core wires. All the wires you just said, because you're crossing it with it. So once you cross it, most of the times these wires you just shouted out, all of them, you can do a basic intervention on these wires. But if you guys want to go with the calcified vessel or anything, you guys have to take a much more larger diameter wire with a stiffer core, like stainless steel wires. Move away from nitinol wires and go to stainless steel wires, and that's where the torque comes into play. Okay, so short taper, long taper. Long taper wires are very good with crossing. If you have tortuosity, especially in tibial vessels. See, most of the wiring torque comes when you're doing tibial vessels or calcified SFAs. Most of the iliac vessels can be crossed, and I'll go over very few times you have difficulty with the iliacs. But most of the difficulty comes when you're going below the level of the inguinal segment. So long taper wires are like filter wires. Command wire is a long taper wire. Any hydrophilic wire which is very lubricous is mostly long taper wires. Short taper wires are very short. They usually used for CTO purposes. They have much more support than normal, and they're easier to prolapse into segments. So what to use when? Now that's when it comes, right? If you make the decision quickly, pretty clear of what kind of wire you want to use, the time to do the case goes down, and it's much easier to make the decision so that you don't have to go in and out with the equipment a lot. And that's where the talk comes into play. It's just to let you guys know what wire to choose. Instead of keep trying on the wire, which is going to keep causing you a problem. Remember, if you guys are doing tibial vessels, the more you push, all that pushing, all that torque will happen in the iliacs and in the SFAs. So your sheath is coming back. If you parked your support catheter in the SFA, that's coming back. So everything is going up into the aorta. So by the time you even realize you're already way up to the level of the renals, now you have to take everything out back in, put a 035 wire. You just added 20 more minutes to your case just because you didn't choose the right wire. That's where the problem comes here. It's not like other vessels like hepatics, renals, or carotids. These are different because it increases the length of time for the case and increases radiation time. So stainless steel wires, very good for support. If you want to get equipment through calcified vessels, great to put things in. But torqueability is very less. Deformity happens very quickly. Nitinol wires, very good to torque, very good to cross lesions, and torqueability is great. So if you really have tortuous vessels, it's a great vessel to go through. And if you want to traverse through the pedal vessels, nitinol wires give you much more amount of torqueability. High tensile strength stainless steel wires, usually these are O18 wires, which are actually great to happen when you're crossing popliteal lesions or SFA lesions and you want more support through the calcifier and you do not want to put an 035 wire down into the tibials. These are great wires to put in. So tip style, core to tip. Again, as I just said, a command wire is a core to tip wire. It's a great wire because it has much more tip control, better steering. You can steer it through, especially if you want to get through the branches, if you want to get into the plantar vessels, if you want to get into the popliteal vessels, if you want to get from pedals. These wires are very good because they can be easily. And what happens is that there's a shape retention. Once you shape it, this shape is retained. So you don't lose the shape. You don't have to keep changing the wires multiple number of times. That's where the advantage comes. So again, shaping ribbon, these are reshapeable wires, just like your run-through wires if you ever use, or BMW wires. They're atraumatic. They're not that traumatic. They're like command wire is pretty traumatic. I mean, if you really puncture the vessel, yes, it can, but it's a great wire to cross lesions. But if you have a BMW wire on the surface, the tip is very soft, but it's very easily prolapses. It loses the shape. You have to keep taking the wire out and reshape it. Again, adds time. And again, once you cross, the shape would have been lost. And if you want to cross a second CTO, now you have to make sure that you get the equipment through before you pull the wire out. Command is not like that. Command is different. You can be, and it's also hydrophilic and pretty. It's nitinol based, so it has a little bit of strength, but it will give you support to get in. Savion also, same thing. You can get things through, and then you can reshape. The shape is retained, so you can cross the next CTO if you have multi-level CTOs. Coils. So these are not extremely important in general to cross in peripheral side. Outer coils really don't make much of a difference because most of the outer coils are all polymer based and they are also nitinol based. So it's really the polymers are pretty coated, so it should not be a problem here. So the covers are again they're all most of the wires we use now in endovascular space or peripheral intervention space or in any interventional cardiology space. They're all hydrophilic wires. Hydrophobic wires are extremely less used nowadays. Lubricity, again, as I just spoke to you about, most of them are all hydrophilic. Extremely rarely we use hydrophobic wires. Again, how does the lubricity and covering and coating change? Very less, but again, you have to know this point. The more amount of polymer coating you have lot of lubricity, but your tactile feedback is much less. It's just going through and just passes through. The more stainless steel coating, the more non-coated the wires are, the more tactile feedback you get on the vessel. So, as any intervention, any interventional space, doesn't matter what interventions you guys are doing, everything depends on two categories. One is a workhorse wire, which you guys use to do every single case. Literally, you go and tell your techs or the nurses or anybody in the says, okay, my case, this wire is open no matter what. Everybody has their own workhorse wires. See, I have my workhorse wire is command, and in coronary space run through. You could be something different. You could be BMW, you could be Savion, you could be any other wire you want to use. Again, it all depends on what kind of wire you're used to. That wire is open. I usually say workhorse wire should be a wire which should be able to get a 1 to at least 2 torque, flexible to go through tortuosity, and non-reshapable. So the shape has to be retained. At least in peripheral space, this is the workhorse wire qualities you want to choose. Because you don't want to take away multiple equipments go in, wire comes back, wire goes down. So you don't want the shape to be lost. You want the shape to be retained. Specialty wires are again wires which are used only if you want to specifically use in any cases. Not regularly used in every single case, but retained only for special cases. If you want to deliver a catheter, if you want to deliver a balloon, if you want to deliver a stent, that's when the specialty wires come into play. Workhorse wires, low tip loads, atraumatic tips, nicely go in, versatile, durable. Specialty wires, they are very high tip load, can cause trauma. You have to understand that part. The stiffer wire you use, the more trauma it can create, and specifically used for only special cases. So again, it's exactly as I said, right? So I'll just go over. So Abbott sponsored it, so clearly Abbott wires will be here, but I can give you other examples. So, so workhorse wires are command, which is mine. I pretty much do command in every single case, almost every single case, if I'm doing an intervention. Again, as I said, stereomorphic wide wire, 018 wire. It's a good workhorse wire. Some people use Theromo Gold for pretty much every single 018 accessible case. That's their workhorse wire. Again, everybody is different. So specialty wires like Win wire is a CTO wire. You can use it to cross lesions. Connect is an 018 wire. Very useful to cross again CTO cases and gives a lot of support, much more stiffer. Spartacore is a great workhorse wire. Once you cross a lesion with command and you're unable to get the equipment down, you can change it to Spartacore. It's more stainless steel wire, very stiff, gives a lot of support. The tip is extremely atraumatic, so you really don't have to worry about the tip at all. The only thing is the tip shape is lost very quickly on Spartacore, not like a command. So 3 platforms, and every platform, every wire has its own use. Again, 035 wires and 018 wires are more localized to the iliacs, SFAs, and popliteals. Personally, I would never use an 035 wire in a tibial. Again, I think depends on your training and everything, but I would recommend never to use an 035 wire in a tibial. I never even use an 018 wire in a tibial. That's my style. But again, it depends on your training and who is training you, who's your mentor. So O18s and O14s are literally reserved for tibials and popliteals. If you go into the plantar space, I would say never touch an O18 wire. Try to stick to O14 wires. Again, iliac, as I said, this is exactly what we're talking about, right? In SFAs, you can go, SFAs vary a lot. If it's very calcified and you want to get the equipment down, don't even worry about putting an O14 wire. Quickly change it to an O3. Unless you're using a filter, then it's a different story. Filter wire is pretty capable enough to take most of it. It's pretty stiff wire. But if you guys are doing an SFA intervention and starches or calcified, just quickly change it to an O18 and an O35. Don't waste time. Get the equipment through and just get things done. And most of the stents deploy over O18s and O35s. So Supera deploys over an O18, and all pretty much every other stent goes over an O35 wire and O18s. So again, BTK platform, as I said, it's basically localized to O14 and O18, and that's what I would do. I almost never use an O18 in a tibial platform, unless it's a very large vessel, more than a 4O vessel. Unless I have to cross it and it's very calcified, I almost never reserve it. Some cases, so boring stuff is done. Let's go to some fun part here. So this is a good case to start with. You guys decide. I'll just go from here this way. You can start. What wire would you use to cross this bifurcation? Just throw out any wire, guys. It's not. Light advantage. Okay. Anybody else you would use in any other wire to start with? So the problem comes with glide advantage to start with is, if you're really, glide advantage is, every wire has a learning curve, right? So you have to understand how you are with that wire. If you are starting as a beginner at fellow levels or are right in the first or second year, I would probably start with a much less wire, probably use a Cook-Benson wire, or probably use a Versacore wire, or I would use a woolly wire. I would probably start with that, see how it behaves, and use a softer wire. Because this tortuosity, you have to understand, crossing is one part. Once you cross it, to get the equipment across this is going to be another part. So you might have to cross it with a much more hydrophilic wire. If that doesn't cross, then use a soft. You can go with stiff glide wire or soft Aeromo or Versacore wire, cross it. And once you cross it, once the catheter goes down in, you have to put a supercore wire, much stiffer wire, or Amplac super stiff, whatever you do. Remember, when you put the sheath across, what do you expect in this case? Patient can have abdominal pain. That's expected because you're straightening out all the iliacs. That pain is, so you have to worry about all these things. You have to worry about straightening of the iliac vessels, back pain. You have to worry about perfing the vessels when you're going through this, especially if you have calcium built in it. So all these things you have to worry about. That's why you have to know what vessel. I would probably start off with a softer wire, like a woolly wire or something. Try it. If it doesn't go, softer Remo, and then probably switch out to a supercore wire. Everything is going to straighten out as soon as you put the sheets in, and most of the sheets now available are pretty I mean, they have a lot of braiding in it, but I think they have reduced the braiding in most of the peripheral sheets. So when you go with it, pretty much any sheet you pick is going to go through the counters of the iliacs. Again, calcification, right? Achilles heel for our endovascular space. Nobody knows what to do with it yet. Again, a lot of data to come in. Especially how to cross it. Everybody has a style of crossing it. Some people directly go to an O35 wire to start with. I think Dr. Purushottam probably goes with O35 wire. Dr. Krishnan tries with an O18 or an O14 first. Everybody has their style. So what is right, what is wrong, it depends on your style. So I always try, if it's very calcified and it's a CTO, I directly go to an O35. I don't even waste with an O18 or an O14 system. Stick myself to O18 or O14 first, try to stay as much true luminal as possible, and then decide. Because your therapy changes too based on where you are, and if you're in dissection plane, if you're in a true lumen, again. So here I would probably start with, because it's very calcified, I would directly go with an O35 glide wire. Now, again, depends on stenosis and occlusion, right? Two totally different things. If it's stenotic, you can always go with O14s and O18 first and change it to an O35s. If it's occluded, then the morphology is what tells you. If you want to be subintimal and everything and you don't really care about it, go with an O35. But if you say you want to be true luminal, then you have to start with O14 and traverse your way up, escalate your wires to O18 and O35s. Confiances don't have much roles in larger vessels because you get deformity very well. All these CTO wires which are done with O14s, they don't play a huge role in SFAs or iliacs. They play a big role in popliteals and tibials because your wire technically is almost always going to dissect it and you'll end up usually dissecting the whole vessel anyways. Yes, please.
In your preliminary approach, when you're escalating your wire strategy, do you try to start with a CTO curve and kind of try to cross it that way? Or do you start with a soft curve and try to find the channel first? And if that doesn't work, go for a stiffer wire with a CTO curve.
Okay, great
Just
question.
take the loop and knuckle it.
You asked for surgery or IC? You've spoken like a true IC. So we are like that, right? So if it's an SFA calcified lesion, if it's soft SFA occlusion, and you know that it's short occlusion, I would shape my wire and then try to cross it really as intraluminal as possible. If it's a long segment occlusion, and if you think there is no speck of calcium, calcium is what determines you how to shape your wire. If there is calcium and it's long, like a 30 centimeter lesion, your shaping has no importance in it. You just go in and then, okay, just moving on. Then you dissect your vessel too and go. Dr. Krishnan is already saying this. So.
The one thing I want to say is, guys, I know you're cardiologists, but I think vascular surgery colleagues will agree. I think the vascular surgery colleagues will agree. Time here is very important. Don't pretend that you'll get any bang for your buck by being intraluminal. This is not a coronary. You're not going to leak MBs. You're not going to worsen the ejection fraction. So you want to traverse the lesion with as quick as possible, with as little bit of effort as possible. So whatever that is, so there's no, you look at all the data out there, there's no data in SFA, luminal versus intraluminal, tibial, luminal versus intraluminal, iliac, luminal versus intraluminal, no data. There's no difference. So losing side branches other than the profunda or, God forbid, a genicular collateral, maybe somewhere where you want some concern or a hypogastric. But I mean, if you don't have those problems, just plow through, get it over with. So don't waste your time. That's the thing. You're going to sit there with an 0-4 wire and an SFA for 2.5, 3 hours when it could be done in 15 minutes. No, I didn't say that, depending which collateral. So Peter Ferries has a great saying. So if you talk about losing collaterals, in every restenosis case, ISR, complete occlusion, all your SFA collaterals are gone. The same thing. So what I'm saying is if you can avoid it, you can avoid it. But what I'm saying is that it should, profunda, genicular collaterals, big genicular collaterals, obviously your bifurcation, internal, external iliac, those are big deals. Beyond that, I mean, I wouldn't worry too much about it.
So collateral part, as Dr. Krishnan said, you have to worry about what that collateral is doing for you, right? If that's the collateral which is giving you the infrapop vessels, and you can't lose that collateral. So you have to decide based on what that vessel is doing for you. If that vessel is one of the 1,000 collaterals you have, wasting 1 hour of time trying to preserve that collateral doesn't make sense. So you have to know, as you said, you have to get the bang for the buck. So try not to, if you have a long segment like this case, as you just see, it's a 40 centimeter CTO. Trying to be intraluminal in this calcified vessel really doesn't make any sense. So, yes.
I know you've been talking about the Abbott wires, and for the coronary guys who do CTOs, what do you guys think of the Asahi Act 1 technology, and with some of their slew of wires for infrapop CTOs? What do you guys think?
So personally, I don't use any Asahi Sion wires or anything for below knee. Even for coronaries, I don't use them. I use Gaia wires, but again, they are one of the specialized wires for. I feel like if you have a short occlusions, coronary CTO wires make a lot of sense in tibial vessels. But most of the times, if the tibial vessels are again 30 centimeter long, which most of you guys, if you start doing CLIs, are going to be, trying to get luminal to luminal is not going to play well with you guys. So you have to choose based on the lesion. Short lesions, I would definitely say use specialized wires, cross it, because you can stent it, you can get a better patency and everything, understandable. But if it's long segment lesion, as Dr. Krishnan said, you're just wasting time. As long as you don't spiral your dissection down and create multiple dissection planes, you're totally okay with creating a dissection plane. So again, I'll just skip some. So going retrograde and antegrade together, right? Now that pedals have become a big part of our endovascular space, so I almost never use overnight wires to directly start from pedals, unless the pedal vessel is pretty large. But I always go with an 014 wire and then escalate the wires once I cross through the tibials. Once I'm in the popliteal space, that's when I use an 018 wire. I usually try to do it, and I generally don't put sheets. Again, I try to be sheetless as much as possible. And even if we have to escalate to an 018, we escalate to an 018 trailblazer or some support catheter and then change it to an 018 wire. But again, if you're going, so again, choosing the wire, any 018 wire can be chosen because you're rarely trying to cross from below. You're probably at the, from the top, you're at the distal cap. You just want some support from the distal cap to tear through the distal cap to join both the wires. That's basically what you're looking for. If you're doing primary pedal intervention, it's again different. Then you have to play it through putting a sheath, putting 035 catheters, crossing again. Visualization again is an issue. So again, as I said, short occlusions. So this case is started off with an 014 wire, right? Because this case is a good case to start off with an 014 wire. You can try it. 014 wire is great to start here because it's a short occlusion you can get through, and you know that you can get through, balloon it nicely, probably with a shock wave now, and then put a supera in there. So tibial wires, and I thought this is an interesting case. So if you're coming from above and you want to get through the tibial lesions, you can put an 014 wire from below. You can put any support catheter, get the catheter from above. Again, as use cart, retrocart technique, however you guys want to use it, just joining the wires is the key. So retrograde access, always try to use hydrophilic wires so that you have, you're in the vessel, you're not dissecting the vessel right away. Don't use too much stiff wires. Try not to be subintimal. So for the tibials, again, if you're using a collateral, I think the question just came, how to use in the collateral. So if you are crossing this lesion, I would probably enter it somewhere here. I would try not to lose this huge collateral which is there. So even if you're stenting, you can put a bare metal stent across it, but try not to lose that collateral. And even if you're entering it through the collateral, if you want to come from the collateral through the profunda because it's a flush occlusion, I would still use the collaterals on the top, not the main collateral. And that's exactly what happened here, right? We used a collateral, we got in, and we did the case. So as I was just saying, if you want to recanalize, don't keep dissecting the vessel as here. That's what Dr. Krishnan was trying to say. Don't dissect through this and lose this collateral. Because by chance, if you cannot cross it, don't create a plane which you're losing it. All right, any questions?